Hello, I'm Kamal Santamaria. This is Counting the Cost on Al Jazeera, your weekly look at the world of business and finance. This week, though, malaria. There are new drug-resistant strains of the parasite emerging along the Thai-Myanmar border, but so too is the hope of a vaccination. But where's the money? All $3 billion of it. That is the shortfall malaria funding is facing, and it's getting worse. Plus the technology of self-diagnosis, the students in Kenya who've developed a mobile phone app that could save lives. So we're doing it again this week on Counting the Cost. One topic, a major health issue, and the business behind its treatment and its prevention. We are talking malaria, a disease with, believe it or not, a 50,000-year history, but which now is seeing some big developments in the way it is handled. And it needs to as well, because malaria still kills 655,000 people a year, 85% of which, and this is the staggering number, 85% of which are children under the age of 5. But that's an improvement. Between 2010 and 2011, incidence of malaria actually fell 17%, not so much through medication, but through these very simple medicated mosquito nets. They're given out to those who need them the most. A lot of those people in Africa, of course, where the prevalence is highest. In 2004, net distribution was only around 5 million pieces. Now, though, we're looking at 130 million of them given out. As ever, though, that good work is threatened in these tough economic times. Where malaria is concerned, there is a $3 billion shortfall in funding right now. And actually, that's going to be a big part of our program a little later on. Right now, though, we want to put it all in some sort of context for you. The disease in action, if you like, the challenge it's presenting to those trying to fight it. Have a look at this now from Veronica Pedrosa, reporting on a new resistant strain of malaria in Thailand.
The face of malaria in Southeast Asia. It's here that new strains resistant to drug therapies have often emerged before spreading to threaten lives around the world. Artemisinin is a frontline drug for treating malaria. The first cases of a malarial strain resistant to artemisinin were detected 7 years ago on the Thai-Cambodian border. But it's been only recently that the World Health Organization confirmed a similarly resistant strain. It seems to have cropped up independently on the Thai border with Myanmar. The great fear is what could happen if artemisinin resistance spread to Africa, where most deaths occur.
Unfortunately, we are at a tipping point because of the emerging threat like insecticide resistance and resistance to anti-malarial drugs, in particular resistance to artemisinin.
At a major conference on malaria, the World Health Organization called on governments in the region to take urgent action. Currently, there's no treatment to adequately replace artemisinin, so this new strain is a serious threat to health in the tropics, most immediately in Thailand and bordering nations Cambodia, Vietnam and Myanmar. Drug-resistant malaria has historically arisen first in Southeast Asia, but it could happen anywhere. That's because drug resistance is caused by things like bad quality combination drug therapies, counterfeit medication, and overprescription.
If so far we managed to contain it in the Mekong region, but if this is going to spread or increase, I mean, this could be a real problem of treating malaria, like the same problem as multi-drug TB.
World Health Organization officials say that the campaign against malaria needs more money and more political awareness. Without that, the world could be looking at the very real prospect of a deadly disease with little or no treatment.
So what to do about that when you've got new, more resistant strains of a parasite threatening all the good work already achieved in combating it? Well, you don't give up, that's for sure. And the next thing we're going to tell you about is proof of that. The pharmaceutical giant GlaxoSmithKline, which is developing a malaria vaccine it claims could change everything. The key is it's been 30 years in the making, potentially the first malaria vaccine on the market, and GSK calls the early trials encouraging. The vaccine is known as RTSS. It is in the final stages of trials in 11 locations across Africa. Subject to World Health Organization approval, it could all be ready to go to market by 2015. A little earlier in the week, I spoke to Sophie Bernot, who leads the malaria vaccine development program at GlaxoSmithKline.
The first thing which is very important to highlight is that malaria is a huge public health issue in Africa. Close to 800,000 children are dying of malaria every year, which is translated into one child dying from malaria every 45 seconds. And that's really the reason why GSK took the decision 30 years ago to invest into a malaria vaccine. And so as soon as we get the first proof of concept in African children, we partner with the PASS Malaria Vaccine Initiative to co-develop together the vaccine for children. And so we are at a very exciting moment because we have generated now the first efficacy data in the final clinical stage of development of the vaccine, which show that we can protect more than 50% of the child by vaccinating them. And so we do expect together with the WHO and with the different partners that if everything goes well, we will have a vaccine recommended as soon as 2015, which is a big hope for African children.
The key, though, will be accessibility, making sure it actually gets to those who needs it. Now, is that GlaxoSmithKline's problem, or do you have to partner with people in Africa to make sure that this will actually get to who it needs to and be effective for those people?
And that's really important, and that is why I think this partnership is particularly important, because we have not worked for more than 27 years to really have a vaccine staying on the shelf. So we do want together that the vaccine reach the people who really need the most this prophylactic vaccination.
Obviously, I was going to ask what's in this for you, but obviously what's in this for you is creating something which saved lives. However, on a financial business side of things, is there a profit here? Is there something to come in return for you here?
So let me be very clear on that. GSK will make any profit with this vaccine, as our commitment is to make this vaccine, at the cost of manufacturing, so making the vaccine plus a small return on investment, 5%, which will be reinvested into research for neglected disease, such as malaria. So for the company, there will be no profit with this vaccine.
And so it's about putting money back. Well, let me put it this way. Is it a disease which can change over the years, i.e. the money that you make from it can go back into fighting it another 10, 15, 20 years from now?
So GSK spent so far $350 million, and the Gates Foundation, through the PASS Malaria Vaccine Initiative, spent $200 million for developing this vaccine. And we still do expect to spend more than $100 million to go into, the introduction phase of the vaccine.
You've spent 30 years working on this particular one. What else? I'm sure you're not just going to stop here and start on something new. You must be working on something else as well.
So we have already a program dealing with next generation malaria vaccine, because I mentioned to you that we have reached a 55% efficacy against the clinical disease, but we do hope that we can improve this profile so that we can save even more life.
Sophie Bernot, it's been very interesting talking to you, and good luck with the program. Thank you.
Thank you, and it was my pleasure.
So what you heard there is that the money GSK makes goes straight back into refighting malaria, if you like. And that's important because a development like this is just no good without the funding to back it up. And the latest World Health Organization Malaria report has said funds are significantly lower than those needed to meet the global targets. How much lower? This much. $3 billion. And it's not likely to improve either. Major donor funding is expected to peak at only $2 billion. As opposed to the $5 billion required between 2010 and 2015. Right, joining us from London is Dr. Jo Lyons, a reader in malaria control at the London School of Hygiene and Tropical Medicine, also formerly a coordinator of malaria vector control at the World Health Organization, so well placed to talk about this sort of thing. We are in the middle of a global financial crisis still at the moment. This has got to still be impacting this sort of thing, and not just research into something like malaria, into anything in medicine, charities, all these sorts of things. Do they become secondary at times like this?
This is a great threat to the huge achievements that we've recently managed to bring about in the world of malaria control. In the last 10 years, it's reckoned that about 1 million deaths have been prevented, mainly among children in Africa, and most of those prevented in the last 5 years, and the bulk of them by the expansion of coverage with insecticide-treated mosquito nets. Now, those nets only last about 3 years, so they'll be wearing out around now. In fact, the big peak of distribution was in 2008-09. So unless we reproduce them, children who live in areas where there's still intense transmission of malaria will lose their protection. They haven't got the immunity they would have had if they'd grown up without those nets, and they're now extremely vulnerable to malaria.
Are they not easily replaceable? I guess I'm comparing them more to the amount of money and work which has to go into vaccines or treatments or pills or anything like that. The nets are supposed to be an easy win, aren't they?
It is an easy win. It's a very straightforward technology. It's a piece of ordinary netting with a few cents worth of insecticide on it, so the total cost is around $5, less than that these days. And in terms of cost effectiveness, the cost of saving a life in that way, it's really very simple and really very cheap. There were fears, you can imagine, there were fears that when people got the nets they wouldn't use them, but actually that's really not a big problem. 96% of the available coverage is being achieved, so 96% of the people who've got a net to sleep under do sleep under it. And it's really just a question of not treating the nets that we're giving as though they're washing machines. They are durable, but not that durable. They need replacing every few years, every 3 years more or less.
What are some of we use this phrase already, both of us, the easy wins. What are some of the other things which can be done with perhaps more limited funding?
Well, one of the things we can do in order to try to save money in the long run is to try to measure and then choose and then put into our procurement practices the choosing of nets that last longer. So we may be able to for a small cost in the unit price of a net, greatly increase its lifespan. And then, of course, the other big life-saving interventions of the last few years has been the expansion of treatment and availability of treatment, and now diagnosis and treatment. We've got these new, very cheap diagnostic kits, 50-cent odd kits, that can finally take the place of what used to be difficult and unreliable microscopy, blood slide microscopy, to tell you whether or not you really do have parasites of malaria in your blood, and thus to make sure that everybody who gets malaria gets the proper treatment.
So the fact that we're getting a phrase like universal coverage out there, does that suggest that malaria is considered big enough? I guess what I'm trying to say here is that you've got X amount of dollars out there and so many different illnesses competing for those dollars. Where does malaria fit into the pecking order, if I can put it that way? It sounds a bit crass, but I think you know what I mean.
Yeah, I do. Certainly in sub-Saharan Africa, malaria still remains number one. And the biggest killer by far of small children. And globally, it's up there as a killer of children with HIV, with diarrhea, with pneumonia. But in Africa, it's supreme. And in terms of cost effectiveness, it means how much do you have to spend in order to prevent one of those deaths. Again, remarkably good value for money. So we're used to thinking of the best, cheapest, easiest to deliver, most robust childhood vaccines, measles vaccine a good example, as being among the cost effective. For the least dollars you prevent the most deaths. And treated nets are up there in that order of magnitude. So that was really the basis on which the Global Fund a few years ago was founded. It was basically the premise that actually now in the last few years we've developed technologies both for HIV and TB and malaria that we know save lives. The systems are there to deliver them. What we haven't got is the commodities. Let's at least buy the commodities. And yeah, I think it's true that the Global Fund has been extraordinarily good value for money, and its funding crisis is a funding crisis for health in general in developing countries.
And we've got to think about the time factor as well. I guess we were talking to GlaxoSmithKline earlier in this program, who working on a vaccine, and they're very excited about it, as they would be, but they've spent 30 years on that, and goodness knows how much money over that time. It's not just, you know, having a bit of funding now or the next few years that will get you through. It's long term.
That's right. Their vaccine the one they have now. I mean, of course, we hope for better. This is just a foot in the door. But the vaccine that they spent 30 years developing doesn't gives you about the same degree of protection as a net, probably not quite as good, and it only lasts, well, it doesn't last so long. A net lasts 3 years. So still, even with that vaccine, I'm not clear that vaccine at least will be a game changer. I don't think it will be.
That's interesting, because that's the exact words that GlaxoSmithKline were using with us. They did think it would change the whole field, and that
yes,
this amount of work over this.
A better vaccine would. A better vaccine would, but a vaccine that only protects you for 6 to 18 months and gives you about the same degree of protection as sleeping under a net every night. Yeah. I know that not everybody in the malaria world would agree with me, and yes, I'm an entomologist. I helped to develop the technology of insecticide-treated nets. But I think that in any case, the whole point is that whether it's a net or a vaccine, and it doesn't last forever, if it doesn't give you lifelong immunity, you're going to have to keep delivering it. So malaria is not going to disappear from Africa in the next 10 or 20 years. So every time we deliver something that lasts 2 years, we're going to have to ask ourselves, how do we deliver it again in 2 years' time?
Let's just pause for a moment, because I do want to bring in, you've been talking about the Global Fund, and I do want to actually bring in a representative of the Global Fund to fight AIDS, tuberculosis and malaria. It's Dr. Christoph Ben, who's the Director of External Relations and Resource Mobilisation there, joining us from Geneva, and we thank you for your time. I've been talking with our guest in London about the will to get the money into malaria. There is this $3 billion shortfall that we've been talking about. Do you believe the will is there? Putting that money into malaria over other diseases or over anything else, quite frankly?
I think the political will is there. There's a huge commitment to malaria based on the results that have been achieved over the last couple of years. We've seen really malaria morbidity and mortality drop in many countries, and I think many politicians around the world know that we cannot stop these efforts, because it would be a great tragedy if we had to start all over again. And we have to continue and really reach the Millennium Development Goals and reduce dramatically the infection rate with malaria. It is within our reach, and I think the political will is there, but we need to really focus that for the next 3 years so that we can close the existing funding gap.
And how are you going to do that? How are you going to get that money there when there is, as I've already spoken about with Dr. Lyons, a global economic crisis going on at the moment, and people might be less inclined to give money towards illnesses and things like that? They might want to protect themselves more than anything else.
The Global Fund is by far the largest funder of malaria programs around the world. Currently, about 2/3 of all the international funding comes from the Global Fund. So if you have a gap of $3 billion, we will try to mobilize at least $2 billion out of these 3. And we have great support. We have the support of the Secretary General of the UN, of the Special Envoy, Ray Chambers. And we are confident that we can appeal to donors so that they will be generous enough to provide further funding for malaria. So we have concrete plans how we can mobilize that money with the support from the Secretary General and the international community. I believe we can do that. But we need to appeal to all countries who can contribute, not just the kind of G8 countries and the richest countries. It has to be a real global effort. And then I'm confident that we can close the gap. Obviously, it's also very important that countries who can afford increase their domestic funding for malaria.
Where do you channel the money that you have got? We're talking about trying to find more money. What about the money that you've got right now? How do you prioritize that?
Geographically, most of our resources go to Africa. Africa is, affected mainly by malaria. That's where 90% of the children who are dying from malaria are, affected by that disease. So that's naturally where our resources go. Then we are supporting a number of high-impact interventions, particularly the distribution of long-lasting insecticide-treated bed nets, but also treatment and vector control. The most important component, and also what requires most of the resources, is indeed the universal coverage with bed nets, so that every family has at least 2 bed nets to protect themselves from malaria. That's the major goal, and we have increased the coverage in many African countries from a very low base to now 60–70%. That's what needs to continue. But also we need to be able to replace those nets once they're worn out after 3 years, so that the disease does not return.
Dr. Lyons in London, do you like what you're hearing there?
Well, very much, and good to hear that commitment, good to hear, certainly nobody doubted the Global Fund's willingness. Good to hear that you are still moderately optimistic about being able to close that gap. I hope that's true. One of the things, I've just been reading some of the submissions from Rollback Malaria about the current gap, and one point that I don't see in there that I think does need to be emphasised more is that there are places, I'm thinking of places like Zanzibar, places in other areas of West Africa, where we have effectively removed malaria for a little while as a public health problem, and people communities who would normally have quite a high level of immunity have been left without that immunity. That's especially important to keep up coverage there, because we've seen before that when you let things relax, malaria can come back, and when it comes back, the death rate is especially high because people lack that immunity. Even in the last few years where we've seen gaps in the net coverage, that's been seen to happen in Rwanda and elsewhere. So this is a kind of lesson for what would happen if indeed that funding gap does not get closed, the nets do not get replaced.
Dr. Joe Lyons in London, Dr. Christoph Ben in Geneva. I want to thank you both for joining us on Counting the Cost. We do appreciate it.
Thank you very much.
Right, so we've looked at the disease, the treatment, the funding, but really it all comes back to those people affected by these factors. Take Kenya, for example, where there's concern that recent gains against the disease will be lost. Why? Well, poverty, basically. It forces thousands to self-medicate using cheap over-the-counter drugs which just don't do the job. And that's for those who know they've got the disease. You've got countless others who suffer from late diagnosis too. But as ever, someone's trying to get a few steps ahead and is using technology to get there. Catherine Soin takes up the story for us.
Rose Onyango still grieves for her son. Samuel died in December last year. He developed malaria-like symptoms after a trip to Western Kenya. He decided to self-medicate, and by the time he sought professional help, it was too late.
He was not going to hospital because his wife was not there to take care of the children. He would be really cold at night and just kept complaining of a headache.
This is the malaria season, and with more than half of Kenyans living on under $2 a day, self-diagnosing and medicating has become a viable option for many. To them, it's much cheaper to go to a pharmacy to buy medicine than visiting a hospital with all its consulting fees.
Poverty is also forcing many to go for the cheapest drugs available. Substandard generics and counterfeits have flooded the market. According to this doctor, Kenya is losing gains made in 2007 when it was announced that the country had won the fight against malaria.
So we have lost the war on malaria. Malaria is back. A lot of places will tell you that patients are once again dying of malaria. Some people are dying of malaria when they are swallowing the AL, which is generic, easily available all over the place.
This group of students may not be able to control the flow of substandard drugs into the country, but they hope to help in early diagnosis.
History of traveling to endemic malaria
areas. There are medical students testing a malaria mobile phone application. It works as an SMS service. You just key in as many symptoms and details as you would tell a doctor. Your information will be sent to a comprehensive malaria database put together by the students. Within minutes, you'll get a response telling you if you have malaria or not. You'll also be directed to a health facility or a doctor near you.
By having this technology, we'll be able to diagnose whatever condition you have early enough. If you diagnose early enough, you'll be able to consult a doctor early soon enough.
It might be too late for Rose Onyango's son, but the students hope that technology will help. But they also know that it's worthless if the right medicine is not available to patients.
And that's really been the crux of this whole program. The technology and the medicine is there. It just has to get to those who need it. Hope you've enjoyed this edition of Counting the Cost. Once again, special mention to our producer Samuel Hunt, who put the whole thing together. You can send him your thoughts via his Twitter handle, which is on screen right now. Also, you can get in touch with me at KamalAJE or our business editor at Abid Oliver Ali. Email's just fine as well. countingthecost@aljazeera.net is our address. There's also our website at aljazeera.com/business, which links on to the CTC page with a complete vault of all our episodes there. This one will join them too. But that is it for this edition of Counting the Cost. I'm Kamal Santamaria from the whole team. Thanks for joining us. The news on Al Jazeera is next.